So I'm from Boston at Tufts Medical Center. This project was conducted at Good Samaritan Medical Center in Brockton. It's a comparison of perioperative and midterm outcomes between laparoscopic and robotic inguinal hernia repair. These are my disclosures. A bit of background information. So inguinal hernias are the most prevalent abdominal wall hernias. They account for 75% of these, and more than 800,000 repairs are performed annually in the US. Majority affect men, and these have traditionally been repaired with an open mesh or open Liechtenstein repair. So there has been a trend towards more minimally invasive repair of these hernias. In general, we have noted advantages of either platform. With laparoscopic repair, we have shorter operative times, lower cost, and you maintain haptic feedback. And where robotics may fall short in this regard, it can make up with enhanced visualization, a stable platform, and wristed instruments, which are particularly helpful with precise dissection as well as suturing. However, no study to date has shown a clear advantage of either approach of the other. In fact, robotic inguinal hernia repair has been shown to cost more and take longer to perform. That does not seem to have slowed down its adoption, however. In 2010, the odds ratio of a robotic inguinal hernia repair being performed was 1.19, and versus 2015, 49.38. And we expect that number to be even higher today. Therefore, our aim was to compare these short and midterm outcomes between the two approaches. Almost all repairs in the laparoscopic arm were totally experitoneal, versus in the robotic group, transabdominal preperitoneal repair. And the authors hypothesized that there would be no difference between these two techniques. What we did was a retrospective review at a single center involving multiple surgeons. This data was organized into a REDCap database, and adults who underwent MIS repair between 2012 and 2020 were included. Concomitant repairs were excluded to better elucidate the following outcomes listed below. So in total, we had 606 patients in the laparoscopic group versus 547 patients in the robotic group. Little differentiated these two groups preoperatively. We do note a higher proportion of ASA2 and ASA3 patients in the robotic arm. The same can be said about the hernia. Unilateral and bilateral repairs were distributed equally among the two groups. However, what we can say is that the robotic group had a significantly higher proportion of complex hernias. And by complex, we mean previous posterior repairs and previous prostatectomies, both of which can disrupt these tissue planes and induce scarring in this area, incarceration, and scrotal hernias. So in terms of intraoperative variables, we note that the robotic group had a higher or larger mesh size used on average, and operative time 53 minutes versus 42 minutes in the lap group, which is expected. We also note that there's a significantly lower number of peritoneal breaches, as well as conversions to other approaches in the robotic arm. Now, 60 patients versus 52 patients were lost to follow-up in either group, and we had an average follow-up time of 43.8 months for lap and 42.2 months for robotic. Now we're moving on to post-operative complications. The differentiating factors between the two groups was a higher rate of grade 3B complications in the lap arm, i.e. Complications that required re-intervention under general anesthesia. And the vast majority of these complications consisted of recurrences. So 16 recurrences in the lap group versus 4 in the robotic group. And here we see a Kaplan-Meier graph showing the survival of these repairs. The estimated recurrence-free time for laparoscopic inguinal hernia repair was 97.6 months versus 99.6 months for the robotic group, and this was statistically significant. So in summary, despite a higher number of complex repairs in the robotic arm, we saw fewer grade 3B complications as well as recurrences. However, we do note that it did have a longer operative time. Visual analog pain scores, length of stay, and surgical site complications were equal between the two groups. This study does have limitations, many of which are related to the retrospective nature of the study. We were unable to obtain hernia size classifications as well as defect size classifications, as well as cost information, which we suspect would have favored the laparoscopic group. Furthermore, there's a learning curve confounder. We have previously studied the learning curve of robotic inguinal hernia repair, and we found that 138 cases for us seems to be the number of cases required to overcome the learning curve. However, this cannot be generalized to several surgeons and other practices, and we expect that the surgeons involved in this study were at different points throughout their learning curve, and this is something that is difficult to compare retrospectively. Furthermore, longer-term follow-up can better elucidate the recurrences that may have showed up later in the future, and quality of life measures would have added value to this study and are a point of topic for future investigations. So a brief conclusion of the takeaway points are that we had more complex repairs in the robotic group, however, saw less conversions and higher recurrence and lower recurrence rates. And we do note that the robotic group had a longer operative time on average. Thank you, and the floor is open to questions.